All right, so I want to welcome you to our third Science Matters program of this year, responding to a 21st century pandemic with 21st century science. My name is Aubrey and I'm a librarian here with the Chandler Public Library, and I'm excited that tonight we're going to be learning from Dr. Dave Engelthaler. He is the Director and Associate Professor of Pathogen Genomics Division at TGen North. TGen North focuses on pathogen genomics with a specific mission to advance clinical medicine, public health, and biodefense. The COVID-19 pandemic has been one of the greatest challenges of our lifetime, but thankfully, it occurred at a time of unparalleled advances in biomedical technology. Tonight, we're going to learn about and ask questions about the next generation science that has been used to combat COVID and future emerging infectious disease threats. So Science Matters is usually a presentation piece followed by questions, discussion, audience engagement, and then it's always about topics in the science world that impact all of us in one way or another. Our next Science Matters program will be July 14th, and it's going to be on the race to Mars and solar system exploration, and that will be with NASA Solar System Ambassador Alexander Nachman. If you would like to view any upcoming programs, other library information, I invite you to chandlerlibrary.org, where you can see our events calendar and see other library services that we're currently offering. So I'm going to let Dave take over, and thank you for being with us tonight.
Yeah, thank you, Aubrey, and I'm glad to be able to talk with your group, the Science Matters group. This is fun because we get to tape this and people get to view this at their leisure as well. I'm Dave Engelthaler. I work at TGen, as was mentioned, the Translational Genomics Research Institute, and pretty easy to find. So through the TGen website and elsewhere, I'd be happy to field questions through emails and whatnot if we don't get them from tonight's broadcast. So yeah, I'm going to talk about responding to 21st century pandemic with 21st century science, and I'm lucky enough to be able to work for TGen, which is really the home of 21st century science, at least when it comes to thinking about human health. We're all about genomics, and we're all about translating that genomic science into applications in human health, better drugs, better diagnostics, new analytical tools, really to help both the clinician, but also help public health officials too. So TGen, if you don't know, was really founded in Phoenix just about 20 years ago, focusing on the human genome, complex chronic diseases, cancer, Alzheimer's, other neurologic diseases, cardiovascular disease, diabetes, and others. My group up in Flagstaff, we've been here about 15 years now almost, and we focus on pathogens and infectious diseases, which is why you can guess that we've really jumped in and supported the response to COVID-19. So I'm just going to take a few more minutes to brag on TGen and the role we've been able to play during this, because we've been able to bring this 21st century science. Then we'll kind of step back and talk a little bit about the virus itself, the variants that we all talk about and hear about in the news, as well as the vaccines, and then we'll end up with a few other things. So hopefully you'll enjoy this, but let me first really start with TGen and the role that we played. And we have this moniker, the genomic first responders. And that's because we can actually translate our science really quickly. In fact, we jump into a number of disease investigations well before COVID, responded to support outbreaks, new emerging diseases, whether they're in our own backyard or anywhere around the world. So we've been active in this role, kind of part of the public health system, to be able to take these technologies and science and really make an impact. And so it was with COVID. In fact, I'm not going to go through this timeline, but you all remember very early in January is when we first started hearing about this back in 2020, in this new coronavirus SARS-like disease that was coming out of China. We actually, our are continually looking for what's the next big thing, where can we make an impact. And so we decided back in January, we're going to start developing tests just in case they're needed. And lo and behold, a couple days later, Arizona had its first case of COVID. That was the famous case. That was the ASU student that was visiting or traveling from Wuhan, China. So we actually were really very early, and we were, interestingly enough, we developed the very first diagnostic viral test in Arizona. Thankfully, the state lab had a test pretty quickly from the CDC. There were some problems with that, but we had developed our test right about the same time, but we made it different than the CDC test. We never had problems with supply chains. You may remember early on, everybody was using the same test, and so they started running out of supplies. Thankfully, we actually didn't, and we were able to continue to support Arizona throughout the whole pandemic, and still to this day are doing testing. We did detect one of the first 3 cases in Arizona, and then since then, thousands more, of course. We also stood up the first COVID diagnostic lab in Arizona. Again, there was the state lab, but we realized it wasn't good enough just to develop a test. We had to really put it into play because really quickly this was becoming an emergency. So we developed a new federally registered clinical diagnostic test for COVID. And we did that in record time, maybe the fastest one ever certified, certainly in Arizona history. And thankfully we were able to, because then again, we've went on to test then tens of thousands of Arizonans with that. And I know this is very braggy, but I'm really proud of TGen and the work that we were able to do. We helped stand up the first drive-through testing site in Arizona. You remember this seemed a little weird, people driving through in their cars, and then it became very normal. But the very first one was actually here in Flagstaff, just not too far away from us. We helped work with the county health department, and then we did all their testing of samples for the next several months. But what we didn't try to do was be the only place that was testing, or try to test the most people. What we wanted to do is make the most impact we could with the capabilities that we had. So we really focused on making sure that the tests were very rapid, quick turnaround time. So remember, there was all those delays, 7 to 10 days to get your results back. We averaged less than 12 hours for turnaround time, and had 99% of all of our tests within 48 hours. It's just because of the way that we operated, we were able to do that. So we didn't try to take all comers. We only focused then on the people that needed us the most, really the underserved areas. We worked with lots of the tribal nations in Arizona, working with the nursing homes, which was the most important place to test, working with shelters and corrections and other places that typically would have a hard time getting infectious disease testing. That wouldn't be normal. And we also improved to make it easier so that we could use saliva for testing, or use dried blood spots. So you could do self-collection of blood for doing the serology or antibody testing. And then I think my last braggy slide is we've been the only lab to provide genomic analysis throughout the entire pandemic. And that's where we're sequencing that genome, and I'll come back to this a little bit here in a minute, sequencing out the genome of the virus, and then building these family trees, understanding the variants, and then using it even for epidemiology and tracing outbreaks and understanding when virus came into the community, how did it spread, and could we jump on it quickly to try to lessen the impact, especially to the most vulnerable. And the last part of that, we also did the genomic epi for the Major League Baseball last year. We were supporting them, which is maybe the only fun part of all this. But we were able to, essentially use this in other ways we didn't expect. Okay, so let's step away from TGen and really talk more about the virus, the variants, and the vaccines, and how technology was used, especially this cutting edge next generation technology. So the virus itself, I'm not going to do too much hardcore science, but in some of this, probably most people know. But you remember this thing's called coronavirus because it has this kind of crown of spikes around it. And those spike proteins on the outside of the virus became very, very important. I'll talk about why in a second, but that's really where the naming came from. And then we understood really what part of the family tree that this new what we call SARS-CoV-2, we called it novel coronavirus for a long time. where it fit into, and it seemed to be somewhat closely related to the original SARS virus. That's why we call it SARS-CoV-2. And in fact, if we look at the family tree, we can see that these are, this is the group of beta coronaviruses that SARS-CoV-2 fits into. And in this group, this is the SARS group of viruses. They all seem to originate from bats and then spill over into humans. And sometimes there's an intermediary, but the original home for these viruses is in bats. And this is the SARS-CoV-2, and it does fit right in the tree with these other ones. That's why we've been saying from the beginning that this is a SARS-like bat coronavirus. And it fits in there. Now, there's the whole discussion about, did it come from a bat into a human, and that's how it started? Was it worked on in a laboratory and it spilled out? That's a whole nother discussion. I'm happy to have it. It's very interesting, a fascinating tale. But I don't have probably the time tonight, but maybe at some future point we can discuss that. The important part here is that we started to really understand the genome of this virus. And by doing that, we could really develop the family tree as the pandemic progressed. We could, what I call kind of the ancestry.com for COVID, really understand where the virus was coming from, where outbreaks are and where they're not. Which of these viral mutations would cause new strains that were going to go on to be very successful, and which ones would peter out. And then also here specifically in Arizona, we could really do a deep dive and understand the pandemic as it came into the state, as it progressed, virus coming in and going out, and then watching these new variants over the last several months as well. We'll talk more about these, what happened with the variants in Arizona, but let's talk maybe a little bit more about what these variants really are, because I'm not sure everybody knows why these variants are important. So if we look at this cartoon picture of the coronavirus on the inside here, we could see again these spike proteins on the outside. That is the actual crown of the virus that we were talking about. And then these spikes are essentially a protein that's part of the genome, and we can find the gene for that spike protein within the genome. The cartoon of that is on the outside here. And so here in red is the spike protein gene. Now, what's really interesting is that the spikes is where the virus interacts with the outside world, and importantly, where it interacts with human cells. And so if you get some mutations on that protein, if we look straight down on top of this spike protein, this is what it would look like here in the middle. And these little letters and numbers are pointing out different places where some of these mutations have shown up and how it might change that protein just a little bit. And you can imagine now, I'm looking at the spike protein here. This is the human cell up top here. This is a receptor on the human cell. We call it the ACE2 receptor. That is where the virus interacts with the human cell and then makes its way into the cell and then replicates. So if you have some mutations that are changing how this protein interacts just a little bit, sometimes the virus won't get in at all. And then that becomes a dead end mutation. But sometimes it allows the virus to get in faster into the cell. And then that can cause increased replication, increased speed of replication, and faster transmission. And lo and behold, that's when we get these new variants because of these mutations that are occurring in these very specific spots. So here in Arizona, we've been tracking these variants really closely. TGen has been hosting this for the state, but bringing in all the data that's coming in from different places that are sequencing, including CDC and ASU and U of A and the state lab. And this is pretty recent data here. In fact, this is updated just in the last probably few hours. But we can see on the side here, all those names you've been hearing about, those different variants that are showing up, where they've been coming from, and now they're getting new names like the Greek letters. So Delta for the new variant that came out of India, also known as B16172. So you can see why nobody's satisfied with the naming and everybody's got to come up with a new one. So that's what we track here. But really the most important ones early on were the one that came out of the UK that was right at the beginning of 2021, maybe actually in December of 2021 started showing up and spreading. That one has become really dominant. We had a couple variants in California that were also very rapid transmitters. Those were dominant for a while and then are starting to drop off. I'll show you that in a second. And then there's also the one out of Brazil, which is also really important, also called P1. And then there's some other ones that are called variants of interest, and we track those also. But if we look at kind of the proportion over time, we can see this is May and June put together, that's mislabeled. But then this is April, March, February. So going back to the beginning of the year, and we can look at the proportion of these different variants. So in this kind of teal blue, very little in January. This was that UK variant here in Arizona. Then the also called B117, started to grow February, March, April, and it's become dominant now. This is the dominant strain in Arizona, but it's been holding about this same level. Now, we've all seen that the cases are dropping off, but the few remaining cases, or the smaller amount of remaining cases, are these variants which are the most successful. So this is kind of like, you remember in biology, thinking about evolution, the survival of the fittest, all of that. It's exactly what's happening here. It's a survival of the fittest. It's kind of the race to see which of these variants are the most fit, and they're the ones that are going to be most likely to spread to the next susceptible individual. That means that when you have a population where more and more people are becoming immune, that means there's fewer and fewer susceptible people that can actually get infected. And so the virus that's most effective at transmission is going to be the one that survives. And that's what we're seeing here. Interestingly enough, this Brazilian one, the P1 strain, really didn't show up until March, and is now becoming an important part of what we're seeing. And then this light blue one here, that's the Delta virus, the one out of India, is actually starting to creep up. It's about 2.5%. CDC just said today that it's about 10% when they look across the country. So it's definitely increasing. And we know it is a rapid spreader. So it's going to be one of those surviving variants at the end for sure. And then we can look at different parts of the state, which variants showed up when, and which ones become more dominant. Again, the UK variant is the most dominant across the state. And then there's a couple like this one here is really a US-Mexico variant. And we really only see it in the southern counties in Arizona. And then if we look at the Delta, we can see those two little circles maybe on there. That just means that we don't have very much. And we've only seen it so far in Maricopa and Pinal counties. At least from sequencing, it's likely throughout other parts of the state as well, and we'll continue to watch it. And one last look at the variants, just kind of cool, maybe kind of psychedelic look. But this is looking at a timeline from January 2020 all the way now to June 2021. And again, that proportional mixture of the different variants. And what's interesting here is this group right here was the original strains out of Asia. Those strains have just petered out by about July of last year, and then they just disappeared. We don't even really see them. It was the strains that were coming out of Europe, which are all these up here, and then the ones down here too. You can't really tell that by looking at this, that really became dominant, stayed dominant, and have become the most successful. Then all the variants that we're seeing now are essentially substrains of those original strains out of Europe. Of course, that strain originally came out of China too, but it did pick up an important mutation that made it very, very successful. So we were having variants all the way back and towards the beginning of this pandemic. And then I mentioned this being tracked by CDC at the national level too. And the most dominant one is the B117, the UK variant. But the Delta variant is creeping up, and it could become more dominant and start to replace the B117. We'll have to see. So let me talk a little bit about the state of COVID. You guys all know this. I'm not going to go through the epidemiology of this, but just looking out here at the tail end of this, April and June. Sorry about that. We've just seen the cases have just dropped off and have stayed dropped off in Arizona. The deaths, the same thing. And then the visits into the hospitals, very low levels, really what we saw at the very beginning of the pandemic. And this is the good news. The virus has now dropped down to low levels. The bad news is it hasn't disappeared, but we didn't think it would. It's still hanging around. And we'll talk a little bit about why that's the case. But we just have seen the deaths drop off to very low levels, and that's because we vaccinated the most vulnerable, the ones that were dying, which were essentially the elderly by and large, and then some groups of other high-risk individuals. We're seeing the same trend also nationally across the US. It's dropped off, and now we kind of got to this plateau. I think it's going to really just look like that Arizona curve. It didn't happen as fast in the US because we actually had some really bad late explosions in places like Michigan, Oregon, and Colorado, but those have really dropped off and subsided. And we're going to just see this hanging around, probably some ups and downs as the virus continues to find susceptible individuals, these very successful variants. Finding them. So let's talk about the vaccines, because it's the vaccines that have made this virus now drop off to these low levels. No doubt that's what's caused this. It hasn't been anything else that we've done other than to get very large amounts of vaccine into individuals. And there we have these amazing 21st century technology vaccines. There's 3 that are out there, at least that we have here in the state: the Pfizer, the Moderna, and the Janssen, which we've all heard about. All of them are very safe, incredibly safe, and highly effective. We did not expect the effectiveness, especially with the Pfizer and Moderna, that we're seeing. It's the benchmark was going to be 50%. If it was 50% good, the FDA was going to give it a thumbs up. And then we were expecting and hoping that it'd be more than 70%. And lo and behold, it's much greater than that. We're seeing 95% effectiveness in the mRNA vaccines, a little bit less in the viral vector vaccines. And I'll talk about that difference here in a second, the Janssen vaccines, but still very high. Once you get fully immunized, we're talking well over 80% for all of these. But you only need the 1 dose for the Janssen vaccine, which is preferable to some people. So let's just talk a little bit about how these great vaccines are working. And I'm not going to dive too far into the science. So I just brought up these CDC kind of cartoon-like images, but just thinking about the mRNA vaccine, don't even try to read this. On the left-hand side of the screen, the mRNA is this really cool technology where it used to be with vaccines, you would essentially kill the virus and then inject that in, and then you have all this mixture of proteins and your immune system responds to that, and it was pretty nasty. In some cases, we actually used what we thought was an attenuated or a non-virulent strain of the virus and inject that. But sometimes that would actually cause people to get really sick. We've seen that with the live polio vaccine, still causes polio-like cases, are actually polio cases, because it's using a live virus vaccine. But with it, the next kind of generation was, let's just use the proteins that is really important for the immune system to respond to, and we'll put that into a vaccine and inject that, and then the immune system could respond to that. Well, that still was somewhat a crude way of developing vaccines. What we've done now is realize that it's we could use just the blueprint for those antigens or for those proteins, put that into the body cells will just read that and then make versions of those proteins, and then the immune system would respond to that. And so that's what the mRNA vaccine is. It's just a tiny little blueprint that essentially allows your cell's machinery to generate the spike proteins, and you kind of see that here, so that your body responds, it develops antibodies, you get the T cell response and other parts of your immune system responding, so that the next time that it sees it, like when you get a possible infection, the immune system responds really quickly. But it works so well, the vaccine, that your body's immune system is working overtime, that you actually, a lot of people felt symptoms just from getting the shot, especially if they got the second shot from these mRNA vaccines. And that only meant that the vaccine was working, that the immune system is responding, that it's doing exactly what we wanted it to do. The Janssen vaccine's a little bit different, probably not as far advanced as the mRNA vaccine, but it's still pretty advanced, because what we're doing is we're just taking that blueprint copy, putting into a different kind of a virus, which has absolutely no effect on humans. This has been proven time and time again. And the virus doesn't replicate at all when it's put into the vaccine. So that virus acts like a vector for that little bit of the blueprint. It gets in, again, your cells, machinery takes that information, makes the spike protein, and your immune system responds to it. And that's why these vaccines they're cutting edge. They've worked really well. But what everybody says is they came out too fast. They came out so fast, and I say, really thank goodness for that. but they did come out so fast, which just made a lot of people hesitant about using the vaccine and not even sure why we allowed it to come out so fast. Well, there's a few different reasons. One, we already knew a lot of information about coronaviruses. We had already been working on vaccines for SARS coronavirus, which was very, very similar to the SARS-CoV-2. So we were ahead of the game, and some of these technologies, even the mRNA vaccines, had been developed in other cases. So it's been a technology that was being proved over the last 5 to 10 years. Also important, the US, especially the US, but some other governments also invested a lot of money to support the vaccine companies so that they actually could de-risk putting all this time and energy into this. They didn't have to spend the billions of dollars of their own money to really move forward with a vaccine. So that was taken off the table. They could just focus on developing this and getting into clinical trials. And then the clinical trials really went very, very fast. And that's the biggest reason is that because we were in the middle of the worst pandemic that we'd seen in the last 100 years. So we had virus everywhere. We had cases going on everywhere, a lot of infection. That meant there was a lot of interest in being part of a trial and then a lot of exposure, which we could then test people against. We wouldn't have been able to do this with other pathogens that weren't causing a pandemic, didn't have such a high infection rate, because we would have to test it longer to see when people get exposed. So that shrunk the time for the clinical trials down from maybe 18 months down to just a few months. And then the manufacturing occurred at the same time as doing the trials. And that's really key, so that as soon as that they got approved, the vaccines could be shipped out. Again, this has never happened before. So we got to, that we can chalk up to the Operation Warp Speed. All of that really made the difference. And then all of the energy over the last 8 months or 7 months to get these vaccines out, working with all the public health departments and all that extra time and energy spent has been remarkable and has gotten the vaccine out. There was delays, there were issues for sure, but we've never done anything like this when it comes to infectious disease. This was the moonshot, the landing on the moon, if you will, for an infectious disease response. And as we talked about, it's the vaccine has really increased our overall immunity, and we're almost there. And we might actually be about as good as we're going to get, but it's going to slowly and continually increase. Not because we're going to have a lot more cases, because we're not, but because more people are getting vaccinated, because it's easier, it's more convenient to get vaccinated. But if I do some calculations looking at the types of vaccines that have been used, how many have been put out there, and looking at the amount of immunity that we actually got from our cases, and then some people got both the vaccine and were previously infected, we can see this is really rough, but very conservative, that I think for the group that counts, which is really over 15 years in Arizona, and that's because that's where the virus is spreading, we have somewhere between 64 and 72% immunity. Again, I think on the low side, it might actually be more than that. So we have a lot of immunity now, more than we've ever been able to do in such a short period of time. So I think what's happened is remarkable, and it really is the 21st century science making the impact, stopping the pandemic, at least here in the US. We still got to get vaccines out to the rest of the world. That's going to take a long time. But in the US, the pandemic is definitely coming to an end. One other sciencey slide I want to show, and I just want to walk through this because I think the findings are really cool. This is a recent study that just came out, and it's looking at the immunity as well as then the variants of concern. And in this study, it was really focused on B117, which is the UK variant, and then B1351, which is the South African variant. Now, that one's of particular interest because it does have a mutation that seems to evade some antibodies. And so we've seen a lot of information about this coming out, about how maybe the virus is starting to evolve to escape immunity. Well, this one does have some of that effect, but the good news is that it doesn't have enough of an effect, and the vaccines are still working tremendously. So let me just walk through this. On the yellow, these yellow dots shots. This is looking at people who were never infected, but then they got the vaccine. And then looking at their serum, their antibodies that they generated, and comparing that then to the virus. How well do those antibodies respond to the virus? And here with the WT, that's wild type. So that means not one of these critical variants. And then the B117, and then the 1351. So getting that first dose, and this is the 2-dose mRNA vaccines, getting that first dose really has a tremendous effect and worked to build up an immune response against all the variants. That South African variant, a little bit lower, but still we're getting good response. And when we look at some of the other parts of the immune system, it's working really tremendously well. So we're not seeing an invasion of the immune system. Then when you get the second dose, bam, this just jumps up to very high levels. And this is why people who are fully vaccinated are not dying. They're not getting hospitalized. They're not getting serious disease. You can still get exposed and get infected, but you don't get as much virus and your immune system responds really quickly. So you might get some of those symptoms, those cold-like symptoms, but that just means the vaccine's working. That doesn't mean that the virus is breaking through and causing disease in vaccinated people. The vaccine is definitely working. Then the interesting thing here too is in the blue, this is the people who had COVID and then they get vaccinated. And so before they get vaccinated, before they get their first dose, they had about as much antibody, actually a little bit lower than people got with their first dose when they weren't infected. So you still get some amount of immunity, but it's not as high as that first dose of the vaccine. But then when you get that first dose, bam, it gets all the way up to the same levels, maybe even higher than people who got the full series. So if you had COVID, go ahead and get at least that first dose because you're going to get full immunity from that. CDC is still recommending, FDA is still recommending getting both doses, but that first dose is what is doing it, especially is for the people who have been previously exposed or previously infected. So that's great news from all that. Okay, so a few other things, and then I think we'll wrap up. And I'm not sure we'll have questions here, but I'll be happy to take them at any time. So a few other things. We've learned a lot, right? There's been a lot of science, and there's been, a lot of confusion about the science, and then a lot of people hear something, and then they really kind of hold on to that, and it's hard to shake that and really, bring in the new knowledge. So I use this line: it's not what we don't know, because there's still a lot we don't know, but it's what we know for sure that just ain't so. That ends up causing us lots of problems. So let me just talk about a few things. And this isn't myths necessarily, but it's the things that we've learned as we've gone along. So masks were not a force field. Masks did not just prevent transmission by themselves, but they provided some level of protection. We see in multiple different studies, including in the laboratory and then looking in real life epidemiology, we saw about a 20 to 60% reduction in the amount of virus that could actually be spread by someone who was wearing a mask. Interestingly enough, no mask prevented virus from coming out, and no mask 100% prevented virus from getting in, not even the N95 mask. But the study showed that they prevented 95% of the virus for those N95s. That's why they call them N95s. That's where it comes from. So that worked the way we thought. But the cloth masks, the gaiters, even the regular hospital masks, they weren't perfect. And they really only are known to have a 5 to 10% reduction in actual cases. That's because the vast majority of both cases and non-cases wore masks. So by themselves, masks did provide some level of protection, but they were nowhere near what we've got from the vaccines. It's not even in the same discussion. So we can lay that to rest. Masks provided some protection. They're still going to provide some protection, especially for the most vulnerable who haven't been vaccinated. Outdoor spread, we've all heard about this. Not a risk. It was never a risk. It was unfortunately an overblown risk. We didn't know that really well. And I mean, scientifically on the science side, we really did, but it really had to get proven that we did not see transmission occurring outside. It was not a risk. CDC this is one area where CDC did a terrible job messaging that we really should have had everybody outside, kids outside, playing sports all along. This really is, unfortunately, we did it, but we learned this and we know now. The same thing with fomite transmission. That was all the surfaces that we wiped down, and boy, did we wipe down surfaces like crazy here at TGen for many, many months. We still do, and we still, sanitize our hands, but that was not how the virus was transmitted. The virus, we did some scientific studies and showed that it could live on surfaces for a while, for several hours even, but people did not get exposed from those surfaces. And so that was not a significant factor either. School closures. This one's a tough one because it hits home to people who have kids. You always want to think about your kids first. But the study after study before this pandemic and during this pandemic, school closures in primary schools provided negligible or even negative benefit on community spread. So it was not a good idea to close down our schools. But public policy wise, there was a lot of outcry because the science was never portrayed accurately about this. Now, as you get older and as you get into junior high and high school, those kids could actually transmit the virus. They were not getting seriously ill either. Of course, we always have outliers and one-offs. We have that with every disease, and that's what get all the news attention. But by and large, this was not a disease of kids. So then the other concern would have been teachers. That's where the focus should have been, is protect the teachers, not from the kids, from each other, and put all of the safeguards in place to prevent them from interacting with each other. But they should have been interacting with kids face to face. I had kids that were out of school. This was a kind of a tough one to swallow, but we didn't do this one correctly either. The lockdowns. So the most serious lockdowns up front absolutely stopped the spread. It shut down everything, shut down the economy for a while, but it didn't stop the pandemic. And the reason why is it kind of just made the pandemic go into quiescence for a short period of time. But we could not stay in a lockdown mode. That we, as a civilization, we couldn't until we had vaccines. So we had to get back out, and then the virus would spread around again. So unfortunately, I mean, we learned this, the lockdowns do work, but you can't stay in that forever. So it can give you a little bit of time to try to figure out what's going on, but then, what was going to happen happened. The pandemic was going to roll across the population, and in the end, it rolled across all populations almost exactly the same. Some had it worse early, some had it worse later, but when you look at the numbers in the end, pretty much everybody just got pummeled by this pandemic, no matter where you were. The other concern was suicides, and thinking about everybody stuck at home, the isolation. We really did think suicides were going to spike. And in the end, they did not. They did not increase significantly across the board. There were very few specific instances where we did see increased suicides. But what we did see was crisis counseling needs skyrocketed, and substance abuse and drug overdoses also skyrocketed during this. So let me end with a couple parting words. Science and humanity. The science was really important, and it was important to understand that science itself is just this continuum of knowledge and learning. And sometimes we learn that what we thought for sure just ain't so. And we got to be able to take that in and understand that and be able to shift and move with that. But I think that science itself should neither be used as a punchline or as a weapon, but rather as a tool to illuminate how best to serve humanity. Science is one of these great, not just inventions of humanity, but a great part of our evolution as a species in learning how we can understand the world around us and use that for our benefit to be healthier and have a healthier world. So with that, we're getting at the end of the pandemic. We do need to start thinking how to act like it. In many cases, people think that we're all back to normal. And in many cases, we are. But those numbers are staying low, but they're not going away. There's still virus around, and we have to figure out what do we do about that. At this point, everybody who wants a vaccine can get it, at least here in the US, certainly here in Arizona, especially the vulnerable and the vast majority of the vulnerable. Over 75% have been vaccinated, the most vulnerable, which is great news. That's why the deaths have stopped. But we got to get more and more of them vaccinated because this is the only thing that will, in the end, prevent those deaths. We have to accept, though, that there is there will always be a risk. This virus won't go away. I think it's a part of us now. It's endemic. It is possible that within a year or two, it does disappear, but we know how to deal with it. We also have to accept the fact that some people aren't ready for this pandemic to be over, that we still have people that are really concerned. And that fear itself won't go away immediately, and it won't go away the same for everybody at the same time. Everybody's different, and we have to get used to this on our own time scale. So people need to make their own choices, and that's okay. So whether it's about still wearing a mask, great. About not getting vaccinated, well, I'm not gonna say great, but that's your choice now. And to me, that's okay. So we shouldn't be doing mask shaming or vax shaming. Either way, we shouldn't have at all. And unfortunately, we allowed politics to really guide a lot of what we did and how we thought about this and how we acted to each other. We got to stop that. We really got to start serving humanity a little bit better. A couple other interesting things. I promise, Aubrey, I'm almost done here. Some other impacts, at least when I think about this, and thinking about past pandemics, and I've studied pandemics for a very long time, trying to understand what are some of the things that are going to occur and think moving out. So I think the mental health pandemic that occurred right alongside this infectious disease pandemic, which is not just individuals with mental health problems, but us communities and societies with mental health problems, it's going to lead to prolonged mistrust. We have more mistrust in government. We have more mistrust in science. We have more mistrust in each other sometimes. And that's going to be difficult for us to get past. There's also an absolute increase in substance abuse. We're going to have to learn as a society how to kind of dial back from this to get back into being the productive individuals we were beforehand. Businesses have changed. A lot of their structures have changed. A lot of cases, they realized they don't need employees doing some of the work that they've been able to replace with robotics. In some cases, you don't need as many employees, and we're working virtually. We've had businesses closed that will never come back from this, unfortunately. It's changing the workforce. We do have increasing unemployment and increasing homelessness. That's something we're all going to have to deal with in our communities. Also, interestingly, the greater use of technology, so like virtual work, is actually making big cities less relevant, and except, unfortunately, to house then the unemployed and the impoverished. Now, of course, the big cities are not going to go away, but they're going to not be as relevant to our everyday life. And a lot of people who've worked in the big city, because that's where they had to work, can work in the suburbs, can work in small towns. So small towns are actually, and we see it in Flagstaff, but we see it in other places too, are actually getting a lot more residents moving in because they don't need to work in the big city anymore. Governments have a stronger capacity for surveillance, both for pathogens and for people. So great for pathogens. We've got to use that now. We've got to accept this 21st century technology. But I'm not sure we need to be doing more surveillance on people. I think that's a bad road. We see where that goes in other parts of the world. So we're going to need leaders that are carefully thinking about this too. And then this trust in science, we have this great divide because I think a lot more people, their trust in science is definitely lowered. And then a lot of other people, it's become like a religion to them without even understanding then what science is and thinking that that's what they've got to listen to. And that's what they have to follow. So I think that we've got to try to figure out how to bring these groups back together, that science itself isn't the perfect understanding of immutable facts. Science is this continuum of learning and understanding sometimes we are wrong, and then being able to move on from there. And then my last point, which is really more of a serious point, is that elder care can no longer be ignored. This is, you wouldn't think that that's true. You know, we put a lot of money and a lot of time and a lot of amazing people working in our nursing homes, working in assisted care, assisted living facilities. But you know what? We didn't, that's where we had to put all of our eggs in that basket, or a lot of our eggs in that basket. We didn't, because that's who died. These numbers are tough to hear, but 35% of all of our fatalities occurred in assisted living facilities. I mean, that's not a very large percent of our population. That's less than 1% of our population, but that was 35% of our deaths. That's where we should have been putting our time and our energy, giving them our PPE and building the walls of protection around them. Thankfully, now they've all gotten the vaccine. But another number is 10% of all nursing home residents died. Now, I'm not talking about nursing home residents that were infected. I'm talking about all nursing home residents died from COVID. That's remarkable. Now, some of them may have died anyways because of other reasons, may have if we didn't have the pandemic. But this one pandemic had such an impact on this very small segment of society. But we generally, and I think politically, really responded to everybody's fears instead of really focusing on the ones that were going to die. And hopefully we can build more capability to support elder care into the future. I'm leaving with this parting thought. I really do think that we, in my particular part of this world, pathogens and infectious diseases, we should be thinking about developing intelligence on pathogens to fight this war before it happens the next time. We can now not just test every case, but we can sequence, learn all of that information, get intel on the next pathogen, whether it's a virus or a bacteria or whatnot, and really do precision medicine, treat the patient for exactly the strain they have. In some cases, it's really what is it resistant to? What drugs can we use? But also use it for public health, have precision epidemiology. So we trace down every outbreak and understand where they start very early on. And to do this, we need to democratize the technology and the data. And really what that means is make it smaller, make it cheaper, make it faster, make it easier for people to understand. And that's one of the things we're working on so that we can be ready for the next pandemic. So this can be done not just by really kind of next generation science entities like TGen, but done by everybody. We can do better investigation of the mutations and the variants, not just at the tail end like we're doing now, but throughout the entire pandemic. We certainly worked a lot with local public health and tribal public health to investigate cases, but it should be something that's just part of public health moving forward. And we've been doing a lot of the training there. And then one last point, we need to prioritize bringing these advances to the native peoples of the Southwest. Something that we definitely made it important to us, that we don't just have this trickle down of technology that eventually makes its way out onto the reservation, that we can work directly with our tribal communities and our Native American brothers and sisters. And that's who's here in Arizona. That's who we really got to bring this technology to as quickly as possible, because they did feel the brunt and had the most serious effects from this as far as different racial populations here in Arizona anyways. With that, TGen, we're a nonprofit. I'm not selling anything other than let's use great science. And there's a lot of great people and entities and foundations that supported TGen that actually got us funding very early on to jump in, to be that genomic first responder. And my hat's off to them. We wouldn't have done this if it wasn't for them. In this last picture, this is a sign on my wall that we have here at TGen. Says we have the ability, therefore we have the responsibility. It's been our ethos. It's what not just allows us, but really mandates that we use this technology to make this impact. And with that, I'm done bragging on TGen. And if there's any questions, great. And if not, I think you'll be able to find me. I'd be happy to answer your questions later.
I think we have a question.
Yes, I have some questions. So the very interesting presentation. Thank you, Dave, for joining us. And just so I kind of want to go down the list of questions that I have in relation to the various points that you covered in your presentation.
Sounds good.
Yeah, so when you talked about these different variants, there's different variants that are kind of, they started as one thing and then it's kind of gone down and they have new variants that arise. So we see this in the COVID-19. Is this something that happens? Is this a typical progress for like a pandemic type of disease? Is that something you see in other types of diseases?
Well, we definitely see this with all pathogens that we study. And that's because essentially when the pathogen gets into a person and it replicates, it's replicating its genome, and then that genome, that replication, it could make an error, like a typo in the genome as it's replicating it. And that error is a mutation. And the vast majority of times, those mutations just, they don't mean anything. They don't do anything. Sometimes they make it deadly for the pathogen itself and it goes away. But sometimes it gives the pathogen some kind of advantage. And now that's a variant. So we've seen pretty much all diseases that we studied that we get these variants. And sometimes they're just very successful only in specific species. So if we look at like the rabies virus, different variants show up in different species and they're adapted to those species and they spread really well, but they don't really cross over into other species. That's a type of variant. We look at something like group A strep, what causes both strep throat, but also the flesh-eating bacteria. That has multiple variants, and some of those variants are actually really deadly. And so we do track those. So what we're calling variants now, we've always looked at as either subpopulations or subspecies or given them different names, but they're really all just different variants because they're evolving, they're picking up mutations, and they can potentially have a different advantage over some other variant or strain.
Thank you. So you talked about kind of some of the things that we were able to do in relation to this particular virus and the pandemic that we already kind of knew about coronaviruses, so we had something to start with. We had money that was poured into the research from the government. People were willing to participate in the studies quickly. And then that manufacturing kind of working parallel with the trials. So what do we learn from this response, this more quick and forceful response to this pandemic? What do we learn from it?
Well, one thing I didn't mention, but the speed at which all that happened was something that we would laugh at Hollywood when they would put that into a movie. You get the vaccine in the same year and you're giving it out. That never happened before. So it really is truly remarkable. And so that means that the model we developed, we can do it again when it's as serious as COVID-19 was. But we can also do it on smaller scale for things that are serious, but maybe not pandemic wide. So like the next Ebola outbreak or the next, Ebola-like disease, something very serious in infecting, maybe a large population center, but it's only one part of the world and it doesn't spread, but it's having a real impact there. We may be able to jumpstart the vaccines this way. Some of those things, we can't do, like the large scale trials. We could only do that because we had so many people being exposed and being infected and so many people interested in participating in trials. So that usually takes a while, but putting de-risking it by government investing in the vaccines themselves and then doing the side-by-side manufacturing, that was the game changer.
That's interesting, and it'll be interesting to see. We hear that, more of these types of things could be coming. And so it'll be interesting to see, like, what do we learn from this to respond to the next one, essentially, especially if there's communication from the places where it's originating, so that they can kind of tackle it sooner than later type of thing. Now, we know that we get a flu shot every year, right? There's a new variation of it. So I'm kind of curious about COVID. I think this is a big question that people have. Like, does full immunity mean like full immunity for a really long time? Whether it's because you got COVID and then you got another shot of vaccine, or you got the full vaccine or whatever, or is it one of those things where we have to keep, doing a flu shot every year?
Yeah, that's a great question. The answer is we really don't know yet. The anticipation is yes, that we'll need boosters. The great news from the data that we're seeing is that the full dose, especially after you get a booster, or if you were infected and then you get a booster after that, you get this really high level of immunity that we're seeing is going out 8, 9, 10, and in some cases even 12 months. Now, we don't have any data beyond that because it just hasn't been long enough, but we have people from the original trials we see still have good immunity after 12 months. One of the things we do know about with other coronaviruses that we're infected with is that we, on average, probably get immunity for about 18 months, and then it really starts to drop off. So then for the same coronavirus, typically you won't get infected earlier than 2 years. Like, so maybe every couple of years you can get infected with the same type of coronavirus. Now you can get infected with other cold viruses, these other coronaviruses, rhinoviruses, and others in the interim. But we do seem to have fairly long lasting immunity that way. But no one thinks that it's going to be lifelong immunity. And we're not thinking that this virus is going away anytime soon, especially given the fact that the vast majority of the world has not been vaccinated. So the virus is still going to be hanging around. We're still going to have travel. It's still going to be popping up, causing little clusters and outbreaks. So yeah, the thought is that we'll probably have to get boosters. We may have to get them for variants, but the variants we have now, we don't need them for. The vaccine's working for those variants. That's why we have to continue to still do all this sequencing to really see what changes are occurring. But yeah, I would imagine maybe once every couple of years a booster's needed. They may try to make it part of the annual, get your annual flu shot. But truth is, you probably don't need your flu shot every year. You probably need it every other year, but it's too hard to remember that. So we just say, get your flu shot every year. We might do that for COVID too.
I just have a couple more questions because I don't want to go over the hour. Can you talk a little bit about the research in terms of the phased approach for vaccines? So starting out with obviously the target of the adult ages, and then it moves down to the teens, and then they're working now with the younger ages or whatever. Mm-hmm. So what's behind that as far as like what is needed to research and study and understand better as you move down down the age brackets?
Yeah, this was definitely a question, how to do this kind of prioritization. What we knew who was at most at risk, and the trials showed that those people still get a good immune response by and large, and that was the elderly. And so thankfully we put a lot of eggs in that basket. Now we put a ton of eggs into the basket of getting the healthcare providers and the emergency workers or essential workers and this and that. To me, that distracted us from hitting the priority group of those people that were going to die. But I understand that they got to weigh these things when they're making these decisions. You know, you've probably seen in the movies, one of them, Contagion, with how they did that was they just did it random. So nobody had an unfair advantage of getting it. And I think it was based off of when you had your birth date or something like that. That's the way we thought we might have to do things like doing a lottery, but really doing a prioritization on who is most affected I think certainly was the best thing we could do, and has now saved a lot of lives. That's why the deaths have just dropped off to next to nothing, not nothing, but down there, because we did target them early on.
Yeah, that's interesting. So, you know, my son is 13 and he's getting ready for his second dose. The adults in the family are fully vaccinated. And my little twin 5-year-olds are like, so what's going on? Like, why can't we get it yet? Like,
that's a great attitude.
Yeah, they're like ready to go, and they don't understand why they can't. Why does everybody else get it, but they don't? So.
Yeah, I mean, it truly is a disease of adults. There's no doubt about it. Little kids can get it sporadically. And the vast majority of those are very, very mild symptoms. And then you have these very, very rare one-off outliers that were serious that got a lot of attention. And so got a lot of people thinking, what about the kids? But this is not a disease of kids. But they're going to get vaccinated because we also just want to shrink the virus no matter where it is. And parents just need that extra surety for their kids. So I think it's great that the vaccine is actually working well in these kids, which to me was actually a little surprising because they were not getting easily infected or easily transmitting it. So certainly their immune system was working a little bit different, but it seems to work really well.
I also just found it fascinating, that last bit that you talked about what studies have shown now that we've gone through a period of COVID in relation to the way that we tried to prevent it from transmitting. And so that the outdoor spread, not a factor, not transferred, or, you're not exposed necessarily by droplets on the surface. You're saying that there's kind of research looking at saying, maybe the school shouldn't have been closed. And I just want to clarify this. In that one slide, did you say that 70% of the COVID cases were people who were wearing masks?
There have been multiple studies now that have shown that of cases, 70% of them wore masks either all the time or nearly all the time. Of non-cases, 74% of them wore masks all the time or nearly all the time. So people by and large wore masks. That's one thing. And that did not prevent you from getting infected. But it did cause a certain amount of decrease in spread and a certain amount of decrease in cases. So it was important, but it wasn't the end all be all, in which I think too much was put on that. So a lot of people started to ignore it because they didn't believe it. And then other people made that, we even heard health officials say it's as important as getting a vaccine. It's not. That's complete fabrication. They're not even in the same realm. They're both, the only realm they're in is that they're both safety and protective measures, but one is really small compared to the other. Vaccine is really the only thing that has made all the difference in the world.
So what's to be learned from what we found through these studies and what we've experienced in relation to prevention in the future?
Well, one of the things is that the masks actually really seem to work, and the distancing and the hand washing for a lot of other things. The flu season completely disappeared. We've never seen this before. It just disappeared. We didn't have a flu season this year. There's been a number of other things that we track. Those numbers were way down as well too. So all of these behaviors really made a difference for other diseases. And so they will likely be important in the future for other pandemics. They just weren't as important. I shouldn't say that. They weren't as effective as we'd want them to be for COVID, but they might be really effective for other things. So hopefully we don't just say, that didn't work for the next pandemic, because it might actually be the thing that does work and gives us that time that we need until we get the vaccine out.
And is there a way that scientists, researchers, health officials would know based on this experience, and knowing kind of if they have the technology to do that intelligence work on a new virus that's coming out, to be able to do a better job of telling the public what really is the best way to prevent the spread?
Yeah,
besides a vaccine?
Yeah, we had these kind of small esoteric niche science studies and researchers that were focusing on aerosol science or focusing on the science of understanding how long things live in the atmosphere or on a desk. And that's where we kind of based all of our information on the little bit of studies that were done early on. But now a lot more attention is on there. This is not a niche science anymore. These are really important things that more and more money is being put into. And so hopefully we're just going to gain more intelligence and be able to learn and know more about the variety of pathogens we have to deal with. Coronavirus wasn't something we'd never even heard of. It didn't drop from Mars. We knew quite a bit about it, but we didn't know about it causing a worldwide pandemic. And we definitely didn't know how to stop it. And I just don't think that we could have without the vaccine.
Yeah. So the information that you're sharing right now in terms of these lessons learned, for example, in terms of prevention, school districts right now, they're in the summer break. Obviously, everyone's going back fully for the most part.
Yep.
And they're going to be talking about their mitigation strategies and that kind of thing. Like, how much is this kind of information going to be available to them in terms of these studies to make their decisions about how they set up the classrooms and what teachers have to do or don't do? I had my kids have gone to two different school districts. And so one is in the Kyrene School District, which was a lot more cautious in their approach toward really taking a lot more preventative measures and not going back as quickly when we were, online and that kind of thing. Whereas the Chandler Unified School District, they had a different set of parents wanting things, take the mask away and all that kind of stuff.
Sure.
So how does that information get out to the schools? And then at the same time, Aubrey and I work at a public library, and we have people coming through all the time. And this has also been a topic of conversation in a public facility like that, like,
Mhm.
thinking about the staff and their comfort level, and also knowing some of this information to help them kind of understand how things work,
Yeah. Yeah. Well,
now that we know about it.
I think if we can have some of these kind of adult conversations where we say, look, we didn't know everything, and some of the things we thought we knew probably weren't totally correct, but we're really learning now. And so one of those things is that some of those, we can put a lot of time and energy and effort into these prevention methods, which do provide some level of protection, but very limited. And maybe the return on investment in those is nowhere near what we get through education about the vaccine and the importance of the vaccine for preventing infection for you, for your family, for your community, and being able to operate a safe workspace, a safe school, all of those things. It's night and day the amount of protection that we get by having higher levels of people vaccinated versus making sure everybody's staying 12 feet apart and wearing masks and plexiglass and all of that. That's providing some level, but a very low level, especially when we have very low levels of virus in the community. And so I would urge against spending certainly a lot of money, but time there, unless we're putting as much, if not more, into education and support of the vaccines. Now, I also just said, people aren't going to get vaccinated, and that's okay. It is okay, but people do need to know that this is the one thing we can do. It's the one thing you can do to really protect yourself, your family, and help keep the virus at bay, so we don't ever have to go through this again with COVID-19, because the vaccine will do that. I hope that answers your question. I'm not trying to skate around it. What I'm saying is that
No, I know
it's in places where we got to put our energy to make the most difference.
Right. I guess kind of what I wanted to know was, like, when you're talking about these studies and you're sharing this now with us, and this is going to go onto YouTube, and we're going to kind of put it out to the community for folks to watch sort of on demand. But, when will this information kind of filter down into, a more general, like, to the schools, to the state, or whatever, in terms of providing that direction to the schools as far as how to operate?
I think part of it is the information is there, but it is difficult for our public officials, especially public health leaders, to say, to say, hey, the pandemic is essentially over. Let's get back to it. But here's the thing. You got to get vaccinated. You got to encourage your staff to get vaccinated. You got to encourage your families, your communities to get vaccinated, because that's going to keep it at bay. We're also going to have to continue to deal with it because the virus won't completely go away. They don't want to say that. They want to say, we still have to do everything possible we can to try to prevent any transmission. Well, without trying to equate all those things together, and they're not all the same. So the public officials know this, but it's difficult for them to say that. They don't want to ever say everything is safe and then everybody back in the water and then there's another shark attack, right? That they're so afraid of that. And I totally get that. I've been in that role before. For the general public, the information is also there, but are people willing to hear it? And we are so polarized, and we're so stuck on what we have been told that is the right thing to believe. Not necessarily what to believe, but what is the right thing to believe. And we believe that. And so, to me, that's really tough. There's a whole community psychology there that I don't think we've figured out how to deal with. And that's when I mentioned the mental health pandemic. We still have that. We still don't trust each other. We still have a hard time hearing things that just don't sound right. For the last month, it's been very difficult for people to think about dropping their mask if they've been vaccinated. For some people, other people, they took their mask off months and months ago, right? And it's difficult for those two different groups of people to even talk about this. And so I think we got to have these kind of open conversations. Hey, we didn't know everything. I didn't know everything. I spent a whole lot of time wiping down things and making sure my staff did, and all of these other pieces that weren't as important. And in the end, it's okay. We've gotten to this point now. The question is, what are we going to do moving forward?
Yeah, that's Yeah, I mean, the whole just, sort of mistrust of the vaccine itself is like pretty prevalent, from friends I have to my own family. Um,
Me too.
Thankfully not my parents, but other parts of my family. And you know, I want them to get vaccinated, but there's a lot of misinformation out there and conspiracy theories and all that kind of stuff. And I don't know what can we do to try to move people past that?
Yeah, I think because we've already have a majority of people that are vaccinated or are okay with getting vaccinated, it's just a slight majority, but a majority, thankfully, that it's just going to become more and more normal. Right now, we've decided to make it a political argument, but soon it'll be, and unfortunately, it's going to take months, but soon it'll be like, you know what? I'm at the doctor's office. They're saying get it. I'll just go ahead and get the vaccine. I'm not going to tell my friends that are against it. But that's, I think, how we're going to get kind of that next segment of people vaccinated and continually having trusted sources, whatever those are anymore, talking about how this is the one thing and admitting, you know what, we didn't know everything. In fact, we were probably wrong about some things, but that's okay because we've learned and we've got to accept when we learn.
Can I ask one more question? And that's about herd immunity.
That's up to Aubrey if she's
yeah, like where are we at in relation to herd immunity?
Herd immunity. So I actually prefer the term community immunity because we live in communities, not in herds. And that means that it's also a very regional type of a situation. So so I think the concept of herd immunity, though, is that you get enough people vaccinated that the virus cannot find the next susceptible person, and therefore the virus disappears. The chain of infection stops. Really, because we live in we're so connected, globally, especially, that just doesn't pertain because people move around and the virus can pop up. And this virus is incredibly, especially with these new variants, incredibly effective at transmitting, at finding that next susceptible person. It's like water, it'll find the cracks. That I think it's going to be, it's difficult to say what percentage in a community do we need to completely stop transmission. That might be, north of 80-85% people that have immunity. Now, you get immunity from getting exposed too. So even if we only have 60% of people get vaccinated, we still have a lot more immunity than that because we've had so many cases. And the virus will actually get into some of these people that maybe just have a little bit of immunity. They'll get a mild case, great, they get boosted. And now we're just continuing to increase our overall immunity, and the risk to the highest risk is very low because most of them are vaccinated. So I don't think that it's not an easy to answer about herd immunity. There's not a specific answer. We just live in communities. The US, the numbers are down. We're going to see them down now moving forward, but we're going to get the virus will keep coming in as we have travel and whatnot. And it's in pockets in the US as well. But most of the rest of the world is not vaccinated. This virus is not going away from them for quite a while.
That's my list of questions.
Those are fantastic questions, by the way. That was a great one-on-one Q&A session. I hope it'll be.
I'm sorry. I just very, very fascinated by this topic and all science in general, as Aubrey knows.
Yeah.
And so I just have so many questions that I want to know.
Well, and a lot of those questions are going to be the same questions that hopefully, a lot of people will come to this video and they're going to learn so much. I really, really appreciate your time and for going over the entire pandemic and just what TGen has been doing. It's such incredibly important work. And also for talking about what we have learned since it started, what we learned we could have done differently. I think it's very important. So I want to thank you again for presenting tonight, and we hope to see you again at a future Science Matters program.
Sure. Yeah, no, it's been great. Thank you, Aubrey, and I appreciate Chandler Public Libraries doing this. Is so cool, and hopefully people get to view this online and then track me down. They can even track me down through you probably. If there's any burning questions that I can help out with.